Okay, hi everybody. Welcome to the third part of our Nclex review. So I have filmed the first part, the second part, and I thought that we will continue on lecture 6. But before that, I know that while you are preparing for the Nclex, it can be overwhelming. I know firsthand experience, as I always say in my previous video, the NCLEX videos, and of course my other videos of motivation and nursing, I say that I'm a foreign educated nurse, and if I was able to do it, then you can. I do not have two heads. All with determination, learning from people, I was able to do it. So I know you can. I am rooting for you. And as much as I can, I'm going to be making these videos to the end so that we can do it together. At the end of this lecture, by the time we're done with this lecture, I'm going to be bringing Uworld questions. So we're going to be answering the new gen questions. We're going to be having like complete 1 hour, 2 hour answering those questions. So yeah, stay tuned. I'd like to pray for you guys. I'd like to pray with you guys because I know that on our own we cannot do this. This is something I do whenever I'm reading for the NCLEX. I just invite the Holy Spirit to help me. So let's pray. Heavenly Father, we are so grateful that you've given us the privilege to learn about becoming good nurses. And for this milestone of our lives, we invite you to please help us. It is in your word that you say we should ask and it shall be given, we should seek and we should find. And when we knock, the door shall be opened. So, Lord, we ask for wisdom from above. We ask that all that we seek, the knowledge, the content that we need to succeed in our first attempt for those that are having this for the first time, or just a repeat test taker, that this will be the last time that they will go through it, that you please help us. We thank you because you shall give us the retentive memory and you shall help us to understand the concepts. Thank you because we know you've answered our prayers, for we pray in Jesus' name. Amen and amen. So we are talking about lecture 6, which is the drug toxicity, Hiatal, hernia, and dropping syndrome. We did talk about the drug toxicities. If you've not watched the first NCLEX review, I do recommend you check it out. I have created a playlist and I'm going to add this live video to that. So in the playlist, if you've not seen the previous ones, you'll be able to watch those ones. But the drug toxicity, I think that it is best that we just remind ourselves what it is about. So we talked about lithium. Lithium, as we said, is anti-manic medication, right? It is used for bipolar. Bipolar has two polar, two poles, two ends of a pole, right? We have the mania and then we have depression. But lithium is used for the manic part of bipolar. And then oh yeah, he also said this is market that it is the manic episode, but not for depression. Sometimes you know how you just explain before reading the things. I actually don't read this. I just try to explain to you guys from my knowledge. And we talked about lithium that anything more than two. So if you see two and above, then it is toxic. Now, what do you remember about lithium manifestation? Remember dry mouth, dry face, going to pee. Remember that from our toxicity lesson? Yeah. So this is somehow how it looks. This is the package. And then let's talk about our lanoxin. Lanoxin, I think, is a trade name. Digoxin is the one we really know. And one thing I know about it back home in Nigeria, when I was still a student nurse, is the very, very little um, strength of the medication. It used to be like 0.25 when it's like a whole medication, or it can be 0.25. So what is it used for? 0.125 milligrams. Yeah. And it is used in the treatment of atrial fibrillation and also our chronic heart failure. So the therapeutic level is 1 to 2. Anything lithium and digoxin, anything more than 2 is toxic. Can you guys see a pattern here? Digoxin and lithium, they have 2, 2. So if you think of 2, then you remember other ones, like you remember our vancomycin, you remember our theophylline, right? They are also under, so over 20, over 20. If you remember the 2 and know which one is under 2 and know which one is over 20, then you'll be able to, in fact, whenever you see drug toxicity, think of the number 2, okay? So, yeah, aminophylline is the theophylline. So it's a muscle spasm relaxer for the airway, everything, the breathing, the air path, and it's a bronchodilator. So what it does is by the time they inhale it, it opens the airways for people with asthma, people with any kind of breathing difficulty. So the therapeutic level is 10 to 20. It means that Nclex doesn't really ask you things that are obvious. They ask you things that you need to know for safety. So being normal, well, that's good. The patient is not going to die. But what they focus on is, do you know that at a certain number that your patient is going to die, which is the 20 they are looking for? So as long as your theophylline level is 20 and above, they expect you to do something. So what I'm trying to say is that you don't really need to cram the therapeutic level that is 10 to 20. You just need to, whenever you see theophylline, you know it's a bronchodilator, used for the airway, and very important, the toxicity level, because that's what the NCLEX is about. Safety, keep the patient alive, prove that you're a good nurse, prove that you can have a client to yourself and the client will not die. Okay, so non-therapeutic level, it means that anything less than 10, then the medication is not going to be effective. It means that the patient is going to progress into asthmaticus epilepticus, right? That one, the condition is going to worsen instead of getting better. So in that case, you increase the medication, right? So this is, I love how this Word document, by the way, I'm going to leave all the documents in the description. So if you want to follow along as you see the lecture here, you can download that note in the description. By the time we are done with this lecture, we're going to go through the yellow book, which will be us answering the questions from everything we have read. And if you are a foreign educated nurse, you want to see the materials I used and my experience when I passed, I'm going to link the video in the description and also the ebook. So if you're trying to like, okay, should I write the NCLEX? What should I do next? I'm still at the boards. I'm still trying to navigate my path. I have an ebook for you, and that will really help you. I poured out my heart and all the resources, frequently asked questions. So you're in safe hands if you get that book. That also is in the description. So we'll go further to the phenytoin. You remember the phenytoin? Seizure, everything, convulsions, which that's what we call in Nigeria, or like seizure, epileptic patients. And remember, the phenytoin, theophylline, vancomycin, they are anything over 20. It means they are toxic in the body. And then we have the lithium and then the digoxin, anything over 2. Okay, so this is how it looks. Important, shake well before use. I like how this like tells you the look. Then we go to bilirubin. This is bilirubin. It's the byproduct of the breakdown of red blood cells. So the normal level in a normal adult is 0.2 to 1.2. So always very important to know, whenever market tells you always test it, pay attention. Actually, all the things we're learning here are the things that you likely see. Not maybe not necessarily the exact question or the way I'm explaining it, but in a twisted, because and clear sometimes they are not straightforward. They're like very analytical. They try to test your critical thinking skills. So you have to read in between the lines. Now, we said normal level in adult is 0.2 to 1.2, right? So in newborns, bilirubin is much higher than in adults. So if it is over 20, then it's a toxic level. And when do physicians want to hospitalize these newborns? It means when the bilirubin is about 14 to 15. Now, there is a pattern. That's what I explained to you guys. I think I'm going before this lecture notes. I should actually read this lecture note or follow the pattern because I'm just going beyond. But I guess you guys understand. What Mark is trying to say in this is that there is a pattern, the ones and the tens, twos and 20s. So if you think about the twos, remember low. If this help, the memory trick is low. Low means lithium, and also the L in low, you can use it to remember lithium and also lanoxin. Lanoxin is digoxin used for chronic heart failure and atrial fibrillation. Now, if you think of the high, that it goes high, it means you have the theophylline, which is the another name for aminophylline. We have the dilactin, and then we have the bilirubin. Okay, so jaundice, what do we know about jaundice? Jaundice is like the yellow stain. You can see it on the picture here. It is yellow skin from excess bilirubin, from excess breakdown of red blood cells, right? And you can usually when you see is in the eye, so the sclera becomes yellow, the face becomes like the rubbed palm oil. So they become really, really yellow. Yeah, so kernicterus is a term that is used to explain when this bilirubin that is broken down, not just in the face manifested or on the skin, when it gets to the brain through the bloodstream into the brain tissue, that is really bad. Like I said, Nclex will test you on things that will kill your client. So anything of the bilirubin that is more than 20, you're like sounding the alarm. We need to do something. We need to do something because these can be very deadly. And it means that it can cause shock. It can actually cause meningitis, that's inflammation of the meninges, encephalopathy. Now, these are the things you read. Nclex will not tell you what can it cause. They just want you to know at what level should you raise an alarm, which is over 20. So there is this manifestation when there is kernicterus, that is kernicterus, bilirubin in the brain. It is manifested in the way the child positions the newborn position. So there is this irritation. So there is this hyperextended, like they really extend their body, and that position is called opistotons. Opisthotonus, if I'm pronouncing that correctly. So in what position do you place an opistotonic newborn? Just put them on the side. I feel like the side is a very good, almost always a very good position when you're doing. In fact, if you're guessing, should I put on the back, should I put on the stomach, should I put on any position, almost always on the side. Remember, if there is breathing difficulty on the side, except when you're doing the chest compression, then you have to put a backboard for stability, and then you do, meaning they are facing forward. But usually you just put them on the side. If there is suction, if there is epilepsy, whatever seizure, you don't just leave them also on the side, right? Okay, so pathological and physiological jaundice. Guys, you need to know this. Pathological is if the pathological is if the newborn comes out like after delivery, comes out with yellow skin, yellow eyes, which is the sclera, something is wrong. Like you're not supposed to be out. That's the pathological. Pathological means it is a disease, you have to do something about it. But if the baby comes, everything is okay, mom and dad doing well, Nigerians will say bouncing baby, girl, boy, and all that, everybody's rejoicing. Then you give them 2 or 3 days after delivery, and then they show that yellow skin discoloration or eye, then it means it's just physiological jaundice. So that brings us to dumping syndrome, but also, and also hyperkalemia. I did read this book, this 92 pages, 4 times. So I recommend that as we do this reading together, that on your own you go through it so that if they wake you in the middle of the night and ask you pathological, physiological, sometimes they will bring this bow tie question in this new gen that put them together and they say a newborn came out with, or the nurse observed, this is how they frame the question, the nurse observed yellow discoloration immediately after birth. What do you do? And then they give you the option of assess and record, meaning just, okay, I can see something is yellow, record it and move away. Or the third one is, or the second one is call the HCP, which is the healthcare provider. What would you do? Will you just say, well, this is physiological? No. You will immediately inform the healthcare provider because you've assessed the baby is just born and there is yellow discoloration. You need to do something. You need to act fast. Okay. I went back to jaundice, but now really let's move on to dumping syndrome. I love these ones. Now, dumping syndrome, they are like, and HL and Hiatal hernia, they are like brother and sister. When one is up, the other is down, kind of, if I am explaining this well. So they are like the opposite of something, but they are really about the esophagus, right? And the GI tract. So it says in both of them, both gastric emptying problems and their opposites. In HRNL, there is regurgitation of gastric upward. Hiatal. I used to like a very good memory trick is hiatal hernia is high. It means it comes the food you put into your body comes up backward, comes high, kind of, if this helps you. But the dumping is like you're dumping things into the trash. When you dump, you don't dump upward, right? You dump downward. So it means that in the let me show you guys the it means that the food goes down too quickly, right? So let's go to the hernia for you guys to see. It says that, like a cow with two stomachs, gastric contents go in two wrong direction at the correct rates. So the signs and symptoms of hernia is just similar to that of GERD, right? Which is heartburn and indigestion because the food is not going in after you take from the mouth. It should go into the stomach, right? But then it comes up through the esophagus, meaning that you feel your chest burning, or clients will complain of chest pain, and they will also complain of indigestion because, of course, the food is not going down, it's not going to the stomach where digestion can start and all that. So yes, you will see the 2H. Now, one thing I like about this hiatal hernia, if you think of HH, hiatal hernia, you have heartburn and you have indigestion, right? But now, the signs and symptoms of hiatal hernia is good. This is when lying down after a meal. So one thing you would tell them, in other words, heartburn, indigestion, on lying down after meal. One thing you tell them is, if you lie down, it means that you're going to have that. So what do you tell your clients? After eating, stand up. If possible, if you're eating, you can, at the hospital, you can bring the table up so they kind of not really stand up, but they are like upright. They don't lie down because lying down worsens the symptom. It actually brings the symptom because it's like bringing the food back. Okay, so treatment, three treatments. Three things they can do is elevate the head of the bed, and this is during the meal and also 1 hour. So during meal, it is okay for them to sit in like a sitting position, but then it's not just after the meal. 1 hour after the, it's not just during the meal, but 1 hour after the meal, they have to sit straight. So also, if you give them fluids with meals, it helps to like bring the food down. It's like pushing the food down, and then increase the amount of carb content. Do you guys know why? Carbs digest faster. But if you think of protein, they kind of stay in the stomach, take a longer time to digest. Is the same as fats and oil. So one thing you would tell people with hernia is avoid or reduce protein and fatty foods. Instead, you give them a lot of carbohydrates, the potatoes, the rice, the way they like it. Well, actually reduce protein. This because the carbs content they encourage the stomach to empty quickly so it doesn't actually go back up. I love this picture about hernia. By the way, say hi. Hi, Charles. Hernia, that's everything is high, everything is coming up. So this is a diagram of it. This is like the esophagus. So from the mouth and then it goes to the throat, the esophagus. And then there is this opening, hernia, hiatus, diaphragm, and the stomach. Since there is a hernia here, the food here stays here for a longer time, meaning they will complain of heartburn, they will complain of indigestion because the food is not going down. Means it's going the wrong way. Instead of it to go down, then it goes up. Okay, so in the dumping syndrome, gastric contents they just go down too quickly into the stomach, so into the first part of the stomach, which is the duodenum. Okay, although they are going in the right direction, very important because both hernia and dumping syndrome, we're talking about the direction. Although in dumping syndrome, they go from the mouth into the stomach, right? Through the esophagus into the stomach, but they are doing it at the wrong rate. They don't even wait for them to be digested. They just like quickly, 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 because I'm afraid that if I don't go in, I'll be like hernia. So let me go very fast, and then they do it so much. I think in these two, there is no moderation, there is no temperance. They are just doing it like on the opposite side. The other one is too slow to go then, which is the hernia. And then the dumping syndrome is like, for the other one to be slow, I guess I have to do like marathon, but this is not supposed to be marathon. That is why. So the signs and symptoms, how clients will present it is there's this staggering gait, there's impaired judgment, there's labile, so all bone gone to gut, there's shock. In shock, we have the cold and clammy skin. There is this tachycardia that's high pulse rate, and then there is this pale look. Now, says add acute abdominal distress. That's like diarrhea, cramping, guarding, borborygmi. Remember our ABGs, right? Hypernatremia, all the highs. Hyperkalemia will cause those borborygmi, that's intestinal sound and movements, bloating, distension. So one thing you should remember in the signs and symptoms for dumping syndrome is that they are drunk, that's staggering gait. Then shock is cold, clammy, pale skin, and abdominal distress, pain, guarding, borborygmi, diarrhea, cramping. So notes, drunk is what it is, shock is what it is. But if you add drunk and shock, you're talking about hypoglycemia, when the sugar level is low. But if you're talking about drunk, shock, and acute abdominal distress, then you're talking about dumping syndrome. Okay, so treatment of dumping syndrome, this should be very easy. It means don't give them caps because caps will digest very fast and go. It means in this case, you're telling them, please lie down. After eating, just go and lie down. Rest. Actually, you can tell them, lie down and eat, right? So that the food doesn't just go straight into the duodenum. Then you increase the amount of fluid during and after meal. I also tell them to decrease the carb content. So three things to prevent emptying of the gastric of the food quickly. and everything low. So what is protein? What is protein is added in the diet? Okay, protein does the opposite of carbohydrate. Like I said, protein will be here. Since carb is what you recommend in HRNL, then you give protein in dumping syndrome for the same reason. So protein bulks kind of gastric content. It takes longer time to digest. Like I said, it moves slower through the gut. Therefore, give low protein in HRNL, but then high protein in dumping syndrome. So now we go to our beautiful electrolytes. You guys, if you don't know anything about Nclex content, you need to know electrolytes. I just mentioned some of the things. I think in the first video we talked about the lab values, but these ones I'm mentioning, you need to know them. Okay. So electrolytes, memorize these three sentences. These sentences was actually what I used when I was preparing, and they really helped me. And this is what I continue to use as I'm practicing as a nurse. So it says kalemia. When you hear about kalemia, we're talking about well, potassium, right? So kalemias, they do the same as the preface. So if we're talking about hypo, it means that everything will be low in hypo, low potassium, except for the heart rate and the urine output. So it means that if there is hypokalemia, there will be like muscle tone -1, -2. There will be sleepiness. Would there be borborygmy? No, because that's like high. Would there be seizures? No. But there will be constipation. There will be no diarrhea. Diarrhea is like the intestine is moving. There will be constipation, right? But then the heart rate will be high, shooting. Urine output high. They go to the toilet all the time. Okay. Then calcemia, they do the opposite of the preface. It means that if we're talking about hypercalcemia, which is the calcium, or we're talking about hypocalcemia. Actually, hypocalcemia is where you see the tetany, is where you see the seizures, is where you see this Chivosky sign. Remember those signs? In the Uworld, you will see them. I actually wrote some of them. The cheeky smile, Chivosky's smile, and all that. Okay. So I actually wanted to show you guys, but if we have time, I will show you guys that hypocalcemia and all that. But I think we should finish this lecture note because in between I have been checking my own resource and also the lecture note. But I think that we should concentrate on the lecture note, and then after the lecture note, we're going to be answering some questions. Okay. Oh, by the way, if you're watching until this time, please take a moment to like the video. Click on the like button. It really helps a lot. And please leave several comments. Okay? Not one, not two. Leave a lot of comments because this tells the algorithm that people find this video engaging. And leave your questions. I'll be able to help. So if you have some questions that you're like, hey, can we talk about this? Can you include it even if it is not in the lecture? I'd love to include that. Okay. And please subscribe. If you've not subscribed, please do. And I do have other videos that is not Nclex review. So if you can watch all the videos that I have been doing, it's really encouraging to me. Yeah, let's keep going. Okay. Hypo. So we talk about natremia. Oh, by the way, natremia is sodium. Remember the value from the first video is 135 to 145. That's normal range. So anything below 135 is like hyponatremia. Anything over 145 is hypernatremia. So magnesium, they do the opposite of the preface. There's something you should know about for you to help, something that will help you memorize is potassium. It's just easygoing electrolyte. It does whatever the name tells you. It's like honest kind of electrolyte. If it says I'm low, I'm really low, the symptom shows I'm low. But you see magnesium and calcium, when they tell you come, go, they do the opposite. Don't trust them. If this helps you, right, in remembering them. So magnesium, when they say Magnesium is like hypermagnesemia. It means that the symptoms will be low. There'll be weakness, there'll be there'll be weakness, there'll be constipation, there'll be bradycardia, bradypnea, that's low respiratory rates, low pulse rates, muscle reflex low, and all that. But when it's hypo magnesemia, that is when we see the heart. If you put EKG, the heart is shooting. There is this to set the point. I'm going to see if I can find that electrolytes EKG strip, because you guys, you need to know this EKG strip to set point. To set actually in my actual NCLEX question, to start, the point is, if I'm pronouncing it well, image. Yes, so this is it. Let me see how I can save this video, this image. Save image as to search. Save. I'm gonna show you guys this because present, extra camera, stop screen. Maybe I should actually stop the screen, right? Should I? Let me see. You have no slide. A computer, upload file. Downloads. Okay, it's not showing. So I'm going to stop the screen because this is very important. I need to show you guys this thing. I really need to show you guys this. Let's see if I can add share screen. Okay, so just a minute, please. This is very important. You guys, you need to know this because sometimes they bring these questions embedded in EKG questions. And if you don't know it, you'll really be missing. Okay, let me see if I can add this. Close. If I can't add it, I will just check from Google. I can't add it, so I'll just check from Google. Let me see. This is not letting me show you guys this. Let me see this. Okay, I'm going to share the screen. This one. So this particular one is the TUSAD. So it goes like really, really fast, very fast. It should be going slowly, but it goes really, really fast. That's it. Let's stop screen share and go back to our lecture notes. Yes. So one of the way you can solve the problem of that to set the point is give them magnesium, because we know what magnesium does. It lowers the heart. It mellows. It's not like lower. Magnesium mellows the heart. So yeah, kalemia go in the same direction as the preface, except for heart rate and urine outputs, which go in the opposite direction. So in hypo, it means hypokalemia, that's less than 3.5. Symptoms go low with hypo, except for Heart rate and urine output, the same. Hyper symptoms will go high with hyper, except for heart rate and urine output. So signs and symptoms of hyperkalemia we have for the brain: seizures, agitation, irritability, loud down. Then for the heart, we have tainted T waves, XT elevation, tachypnea. But remember, don't fall for um, tachycardia because we're talking about heart rate. So what do we see in tachycardia? It goes down. It means we have bradycardia in hyperkalemia. Then the bowel sound, there is diarrhea, there is for the bowel, there is diarrhea, there is borborygmy, then the muscle, there is spasticity, increased muscle tone, hyperreflexia, we're talking about +3, +4. Then heart rate, it means it's down. Urine output down. So there is bradycardia and oliguria in hypokalemia. But in hypo, there is for the brain, there is lethargy, there is bradypnea, paralytic ileus, there is constipation for the muscle flexicity, and then for the muscle tone, we have hyperreflexia. We're talking about the 0 and the +1. Then, but when these things are low, heart rate is shooting high, and the client is running to the toilet all the time. So, question: your patient has hyperkalemia. Select order, apply. We have a dynamic ileus. Is it part of it? Obtunded. Is this part of being high? +1 reflex. That is quite low. Irritable. Yeah. U wave. Okay. Depressed ST wave. Polyuria. Bradycardia. So kalemia goes in the same direction. So the only thing that is correct here is clonus. That's like really high. Muscle contractions and bradycardia. I don't know why I'm not pronouncing this way. Bradycardia. Yes, bradycardia. I can do this. This is me hyping myself up. By the way, one thing I do when I'm studying, when I'm overwhelmed with fear, is I write. Rosalind, I have passed in my first attempt. I'm going to look for somewhere and show you guys where I wrote this because it is very important. Sometimes when you're reading, you feel overwhelmed. This is one of the things I wrote. Thank you, my God, for helping me pass the Nclex on my first attempt. Amen. Write it down and that will be your experience. Okay, let's go on to calcemia. Calcemia go in the opposite direction as the previous. So hypo symptoms are high with hypo, and hyper symptoms are low. Calcemia do the opposite of the prefix. It is a sedative. Okay. So hypercalcemia, we have bradycardia, which is low. Bradypnea, that's heart rate is low, breathing is low. There is this flaccidity in muscle connection, flaccidity. I think flaccid. That doesn't sound well, so I'm just going to keep the word with flaccid. Then there is hypoactive reflexes. So in the muscle tone, we have the 0 and +1. There is lethargy, there is constipation. But when it's hypokalemia, then we have irritability, seizures, spasm, tachycardia. So you guys, please remember these. Nclex bring this a lot. I said Chivosky's sign. Please remember this for hypocalcemia. You see these two, you have to remember them. So because sometimes you can just see as a question like when the nurse was assessing the client and noticed that when she stroked the patient's face, there is this cheeky smile, something like this. What does that mean? It means that there is hypocalcemia. In hypocalcemia, I'm sorry. Yes, it means that there is hypocalcemia. What do you do? Please give them calcium. They're low in calcium. It's usually people that have taken when their thyroid gland have been taken away or parathyroid gland, usually they need extra dose or external source of calcium. And then the trousseau is when you're taking blood pressure and then the inflate the cuff and there's this abnormal muscle contraction in the arm. That is trousseau. Please remember this to the Chivosky of cheek and the trousseau, which is of the cuff. That's how you used to know. Sometimes they'll ask you, how do you check or how do you know that the patient has trousseau sign or what activity the nurse does that presents trousseau. Remember, is connected to the cough, the blood pressure when you're taking blood pressure, and then the cheeky for the Chivosky sign. Okay. Choosing answers for potassium and calcium. For potassium, pick answers relating to heart problem. So if you're talking about heart problem, remember potassium pumps the heart. But if you're talking about the muscle, facial muscle, Chivosky sign, the hand muscle, remember calcium, okay? So magnesium, what it does is it mellows. It's like cool your temper, not the vex too much, that kind of thing. So magnesium mellows the heart. It's like take a chill pill. Don't be too sad or too agitated. So it's also a sedative like the calcium. Okay. It is possible that signs and symptoms are from several electrolyte imbalances. In that case, choose calcium if nerve or skeletal involvement, if there is nerve or skeletal involvement. But pick calcium if you're talking about the heart, generally anything relating to the blood pressure. So your patient has diarrhea. Which of the following electrolytes imbalances causes diarrhea? Diarrhea is hyperkalemia, hypokalemia, hypocalcemia, and hypomagnesemia. What about tetany? Remember tetany is this seizure. Yeah. So, and hypo, it means everything is on the opposite, right? So that's where you see seizures, that's where you see diarrhea, that's where you see Trousseau sign, that's where you see Chivosky sign. So test tip, common mistake, tetany, yeah, is equal to hyperkalemia. Prefix example, pay attention. Okay, so let's go to the hyper and the hyponatremia, which is the sodium level. One thing I used to remember them is exactly as it is written, even at work, when I see the E, I'm like, oh, there is dehydration. The level is over 145. If I see a test result from my client, it comes. If I see that it's over 175, I'm like, hey, it's summer, you need to drink water. Or when I see hyponatremia less than 135, I'm like, you need to eat a little bit of more salt, right? Because the O means there is overload. And what happens? Let's talk about the signs and symptoms of the hyper. Hyper, the E means there is dehydration. So there is hot, flushed, dry skin, dry mouth, thready pulse, rapid heart rate. It means that please give them fluid. If they can drink, give them fluid. If not, infuse the normal saline, right? Give them normal saline 0.9 to into the vein. Associate E in hypernatremia with dehydration, and that's exactly what I used to remember it. Then hyponatremia associate overload. So there will be crackles in the chest when you listen to the lung sound. There will be distended neck vein. There will be edema when you press the leg. Usually in the elderly people, there is this pitting edema. There is, of course, weight gain because there is fluid overload inside. What do? Give them salt, restrict fluid, like tell them to drink little fluid, and you give them. Now, our second lecture comes in, which is the diuretics, the loop diuretics, right? So you give them furosemide. Furosemide is the loop diuretics. It takes out, it's the first medication we give for chronic heart failure. Remember, it's like the first point of call, like, hey, there is this patient with heart failure, and furosemide runs there. Remember what we talked about it, that it doesn't spare potassium. So as you're giving, remember to check your potassium level so that the heart doesn't stop pumping, right? So the nurse diagnosis in this form is fluid volume excess. Question: in addition to a high potassium, what other electrolyte abnormality can be seen in DKA? DKA, remember, is our diabetic ketoacidosis, and it is usually seen in, this is also part of the second lecture if you've not seen that video. It is usually seen in DI, so DM1, insulin resistance, usually in younger children. So DKA, you see dehydration. So if there is dehydration, then we're thinking of hypernatremia. You see the connection. DKA, you need water, because in DKA, what is it? They need water, they need fluid, and then they need you to give them insulin. So we're talking about insulin and more fluid. It means that they are dehydrated, and in the dehydration, there is hypernatremia, meaning that the sodium level is what? Over 1 point, not 1 point, I'm sorry, over 145. Okay, so question again, in addition to high potassium, what other electrolyte imbalance is possible in DKA? Answer: hypernatremia. Review: think dehydration or fluid overload. So in the SDI, SIADH, which is related to the fluid dry inside, keeping fluid, there is hyponatremia because it like keeps fluid inside. It's like holding, oh, it has that water is scarce somewhere. Like the one I have, I'm holding on to it. I'm not letting it go. So it's swelling, but it's still holding on to the water. The little water that is like holding, not letting go. So there will be fluid overload. There will be crackles, distension of the jugular veins, pitting edema, weight gain, because wherever there is water gain, there is weight gain, right? Then we have the diabetes insipidus. Diabetes insipidus is like the opposite, because we're talking about the diuretic hormone, right? In diabetic insipidus, patient is running to go and pee. As they are coming back, they are going to take water because there's increased thirst, right? It means that they are dehydrated because they're always going to pee. They cannot keep water inside. So there is hypernatremia because they are dehydrated. And then we have the HHNK. That is also the other part of when the diabetes 2 is not properly taken care of. It leads to dehydration. You just give water, right? It leads to HHNK. That's dehydration, right? And when there is dehydration, there is hypernatremia. Okay, so how to spot early signs of electrolyte imbalance? The earliest sign of electrolyte imbalance is this paresthesia. There is this paresthesia is muscle weakness. So numbness and tingling in the muscles. Then psychomotor paresthesia is around the lips. So I hope you remember, if you're a visual learner, what I'm doing around my lips will make you remember psychomotor paresthesia. It's like when you want to know that you need to take lab value, you need to take a blood test to check the electrolytes. It's the very first signs, those paresthesias and numbness and tingling around the lips. So, but the universal sign for all of the imbalances is muscle weakness, which is paresis. Okay, so treatments. Potassium is the only one board will test. When we talk about board, we're talking about the Nclex, right? Very important, you guys, potassium, because it is that potent, it is that serious, it is that deadly if you don't know the measures to take care of. You need to know this, what potassium does and what to do. So Potassium, you never, even in an emergency situation, if you're in this emergency department and you don't have enough pump and clients come in, it's better to let that client wait than for you to give potassium by like pumping it or letting it flow you or by pressing it with your hand. Never do that. You could lose your license. So potassium of less than 40 of IV fluid. So if it is over 40 in the prescription, the HCP, the healthcare provider writes, give like 50 into an IV fluid. You're like, hey, are you talking about potassium or something else? Because you cannot give when it's over 40. Okay. So in a situation where we have hyperkalemia, how do we lower it? So of all electrolyte imbalance, potassium is the most problematic, which is why we need to know potassium. If you don't even know any electrolytes, no potassium, it pumps the heart. If the heart is not there, it's like riding a car without fuel. It's like living a life without food, no fuel. The brain just goes, right? Because high potassium can actually stop the heart. So everything over, we have 3.5 to 4.5, right? So the fastest way to lower the potassium level is to give the dextrose 5 in water and the regular insulin. Regular insulin, remember our onset, our peak duration, we talked about onset 1 hour, peak 2 hours, duration 4 hours, right? And this is the only insulin you give into the IV. So this will drive the potassium into the cell and out of the blood. This, like when you give the dextrose and insulin, is like a temporary but very fast emergency, is like the first point of call. But it's the effect will wear off after some time. And that is why we need a longer or more lasting one. So both of them can be started, which is the K-exalate. So this can be given through enema or ingestion. Sorry. K-exalate exchanges potassium for sodium. Potassium is eliminated through feces and becomes hypernatremic, meaning that they become dehydrated. And hypernatremia is then managed by giving IV fluid administration. The downside is that it takes hours to work, and that is why you can start giving the K-exalate as you're giving the dextrose and regular insulin, because by the time the effect of the insulin and the dextrose wears off, but we know that K-exalate's action will start picking up, right? To solve this problem, I think now I've gone ahead of myself. Here it says, to solve this problem, give the dextrose 5 in water, regular insulin, and K-exalate at the same time. Because the D5 in water, that's the dextrose in water, and the regular insulin, they work instantly, but the K-exalate works in a few hours. That's K exits late, comes in late. It makes a show when it comes in. Okay, that brings us to our lecture 7. I'm going to see if we have more time to do this. Yes, we do. So let's talk about thyroid and adrenal glands. I think after this, I'm going to end the lecture. We'll go about, so that when next we come, we'll talk about laminectomy and yeah, let's see how far we can go with this. Prioritization. Prioritization is one that I really want to take a whole lecture with you guys, because prioritization is everything. It is everything. You need to know it. We don't need to talk about psychiatric medications because we've done that in the other video. So I think we have like let's say two more classes, 2 more reviews, and then we'll be done with this lecture notes. Okay, So where are we? We're on thyroid and adrenals. Since the thyroid gland regulates metabolism, whenever you see thyroid, think of metabolism. Thank you for saying it. So we have hyperthyroidism. By the way, if you've not subscribed, you've not left a comment until this point or like, please do. This really, they are really motivating me. It's like you encouraging me and doing your part so that others can find this video. So thank you so much for doing that. So hyperthyroidism. Now you look at the man here. We're going to talk about him. Hyper means is hypermetabolism. Signs and symptoms will be weight loss, the heart rate will be up, the blood pressure will be up, hyper personality like this agitation, easily troubled, easily in distress, easily irritable, shouting, pacing movements if need be. So they can have heat intolerance because everything is like high, like really beating on the ride energy. And so can't tolerate cold because body is like furnace. So you could actually see them in winter not putting clothes on because inside they're burning. So there is this exothalamus, which is the bulging eyes. It means that the eyes cannot even contain the eyes, the skull cannot even contain the eyes anymore. It's like, I'm coming out, let me go out. Yeah. So exophthalmos is seen in grave disease. Run yourself into grave disease. Now, grave disease is when this hyperthyroid condition is not taken care of, then it gets to the other side. It progresses, it worsens into grave disease. So whenever I remember grave, remember thyroid, like you're running into the grave because everything is fast. And when everything is fast, when we talk about metabolism, we're talking about hyperthyroidism. So hyperthyroidism, three treatment modalities. Nuke it. So it's like bringing it down with radioactive iodine. Patients must flush 3 times after urinating. You have to call the hazardous department if urine is spilled on the floor, and then you put patients in a private room at least for the first 24 hours. And visitors are restricted and in hospital. And in the hospital and at home in the first 24 hours. So if they have, I know a doctor, the head doctor where I work, she actually has this. So I was having a conversation with her. This was actually last week, and she said yes, that she's going to be at home, but she's not going to be using the same bathroom with her family because after having this radioactive iodine, you don't want to be exposed yourself or expose others to it. So the other medication that is used is the PTU, which is the propyl thiouracil. So it means it puts the thyroid on down. It's like it clamps, yeah, for a better word, it clamps the energy. Is like, stay in one place. Why are you busybodying, right? So PTU's primary use is for cancer. So you have to monitor the white blood cell because patients can be immunosuppressed. It means that in the other video we talked about neutropenic precautions, no fresh flowers, no fresh fruit, and they should avoid crowds and all that. Then thyroidectomy is the third modality. That's third treatment, surgical removal of the thyroid gland. And remember, when there is total thyroid to answer. So let me just read from here because I know I have this, I see myself going ahead of myself. So I'm just going to read from the note. To answer questions on the board correctly, pay attention to whether it is total, sub, which is partial. Total thyroidectomy, they need a lifelong hormonal replacement. And that's why you see our thyroxine, right? Which is given first thing in the morning. Sometimes night shift people give that before the morning people come in because you have to take it before eating or before any other medication. So it means that patient is at risk for hypercalcemia. And when there is hypocalcemia, there is risk for tetany, seizures, Chebosky sign, Trousseau sign, and yeah, due to difficulty to spare, because the thyroid and the parathyroid are usually connected. You see, the parathyroid is actually attached, if you see the image here, attached to the thyroid. So they will actually need the calcium because the parathyroid makes the calcium. Okay, questions. What are the symptoms of hypocalcemia? Meaning there is paresthesis, there is tetany, twitching, spasm, clonus, seizure, jitteriness, tremor. Everything is up. Also, the Chebosky and Trousseau sign. So treatment of subthyroidectomy do not, well, in this, because the thyroid gland is still there, the parathyroid gland is saved. If not all is moved or removed, they do not need lifelong hormone replacements. Maybe they need supplement at the beginning, but not really at the end. However, they are at risk of thyroid storm. Signs or symptoms of thyroid storm. This is, first of all, thyroid storm is a medical emergency. Is like over the roof, 105 and above. So the first thing is to get temperature down, bring the oxygen up, and then give them or bring body temperature down using ice pack or cooling blankets. Stay with the patient because at that point they're like, what's happening to me? Is death imminent and all that? So just be with it. In fact, whenever you see an option in Nclex, in any question on Nclex, and there is stay with the client, please choose it. You do not want to leave your clients because in the Nclex situation, it is like an ideal work environment that you have enough friends, you have enough staff, you have enough colleagues at work to help you. So don't think that in my normal setting, in reality, we don't have people. In Nclex, it's an ideal situation where you have people. So if they say stay, if you see an option of stay with the client or go and look for somebody, choose the option of stay with the client or stay with the patient, and you'll be correct, 100%. Okay. Where were we? Stay with the patient, high blood pressure, stroke level, severe tachycardia, and they may be psychotically delirious. Lowering blood pressure in thyroid storm. First step is ice pack, but the best step is cooling blankets. So post-op risks in total thyroidectomy and subtotal thyroidectomy. The first hours, the risks are the same for both total and subtotal, which is the first priority is that oxygen is there. Remember our ABG, airway. So, which is due to edema, there will be swelling. But then after the first 12 to 48 hours, you're thinking about infection, right? So here it says the top priority is airway, then the next one is hemorrhage, which is bleeding because it is an endocrine gland. It is very vascular, meaning it has rich blood vessels, right? So it matters for 12 to 48 hours, it matters what kind of surgery you have had. So in the total, there is a big danger for tetany because the body then realizes, oh my goodness, I do not have parathyroid because they wanted to take the thyroid and at the same time they took the parathyroid. So you're like, check out, give them calcium. They need extra calcium, exogenous calcium, right? Then we have in the subtotal, which is risk for infection. Yeah. Hypothyroidism, which is hypometabolism. So, what are the signs and symptoms of hypometabolism? There is obesity, there is the heart rate is down, the BP, that's the blood pressure is down, personality is like flat, boring, dull, like I don't care, don't disturb my life, this is not my day kind of personality. There is cold intolerance. So even if the house is warm, they are shivering, they cannot tolerate heat, right? So, sorry, they are shivering because it means that they can actually tolerate heat. They want the house to be warm, they want everywhere to be warm, and then it to be okay. But if it is a little bit cold, they're like, I can stay here. And they are academically challenged. My eczema is a medical emergency, and it is whenever you think of my eczema, you think about hypothyroidism. So there is severe, it's like medical emergency for hypothyroidism, leading to decreased mental status, hypothermia, and other symptoms related to multiple organ damage. It's a medical emergency. So treatment of hypothyroidism is levothyroxine, which is the synthroid, which is taken 30 minutes to 1 hour before breakfast, taken alone on empty stomach with water, not with alcohol. In fact, if you see any question that you say give patient something with alcohol, you do not give patient, you do not teach patients, you do not advise patient to take with alcohol. Rather, everything with alcohol, you restrain it. So I think that we will end with the thyroid part so that when next we come, we will talk about the child. Okay, let's finish with this. Do not sedate these patients. They are already super slow. So they could actually go into coma. They cannot cope more, like they are already sleeping and you're like, go and sleep more. They won't come out. Questions. What pre-operative order from the physician would you question? So Ambien, Zelpodem at bedtime, right? Don't give them sleep medication because they're already sleepy. That's for patients with hypothyroidism. So question, a patient diagnosed with hypothyroidism will be undergoing surgery the next morning. The physician ordered the patient to be nothing per oral at 12 a.m. Patient is on Synthroid and multivitamin pills. What should the nurse question? First of all, clarify the nothing per oral order for Synthroid. Why? Because the patient needs the Synthroid for he or she to be awake. So it's like I am dying and this is the only medication that can help me be alert, and you're telling me not to take anything. That is where you as a nurse, you come and advocate. Otherwise, the condition may potentiate the surprising effect of the anesthesia during surgery. Therefore, do not hold. This is a situation where you're like, I am questioning. Do not hold the pills unless explicitly ordered in writing, right? Not like mouth is not enough. Put it down. Write your name. Sign it. So we're going to the adrenal cortex disease. Interestingly, all adrenal cortex diseases starts with A and C. So we have the Addison's, which is the hypoadrenalism or adrenal insufficiency, and the Cushing. Yeah. Addison disease is under secretion of the adrenal cortex, which is the steroid. And it says they are a time bomb. So signs and symptoms is this hyperpigmentation, that is brownish kind of skin, and they do not adapt to stress. Question. What is the purpose of stress response in an individual? It is to maintain blood pressure to perfuse the brain and other organs, an adequate level of glucose to feed the body. Question. What could happen if these patients cannot adapt to stress? Under stress, patients with Addison, remember there is low secretion in Addison, they will go into shock. They cannot take it anymore. It's like being drunk, hypoglycemia. Oh yeah, again I went I went before myself, and they have hypoglycemic episode, which is the Addisonian crisis. Treatments, give them steroid, glucosteroid, like everything ending with the zone, prednisolone, methylprednisone, prednisone. In adenosine, you add a zone. This is a very good memory trick. In adenosine, you add a zone. Yeah, this is a very good memory trick. Then in Cushing, we have like over secretion of the cortex. If you have a cushy tushy, you get more secretion of the adrenal cortex. All the signs and symptoms in Cushing. So I actually did this picture in my notes. I don't know if I can look for it, but it doesn't really matter if it's going to take our time. But I actually drew mine when I was preparing. So draw a picture of a little man, give him a moon face, um, give him a beard, Futurism, which is the beard here. Give him a big body, central or truncal obesity, that's big side. Arms and leg are skinny. Bump on the front, that's gynecomastia or big breast, especially for males. Buffalo horn, there's this back. Fill him with water so he's retaining sodium. When he's retaining sodium and water, there's hyponatremia and he's losing potassium out at the back. Give him stretch mark, which is trial. Most important one of all, high serum glucose, high blood glucose. Do echo check every 6 hours. They look like diabetic, easy bruising, put bruises all over him. Yeah, and there is high infection, immunosuppressed. A patient comes in with acute exacerbation of COPD. The patient is being treated with Solumedrol, that's prednisolone, IV, push every 8 hours to reduce the inflammation in the airway. What nursing action needs to be taken when patient is on the medication? Do an echo check, that's the blood glucose check. And since patient is on steroid, his condition is similar to diabetes. So even if he is not a diabetic, the complications are worse if patient is diabetic. Treatment of Cushing, adrenalectomy, so removal of the adrenal gland. What happens if there is bilateral, that's on both sides of the adrenal glands is removed? Now patient has Addison disease, so they will have to have steroid all their lives. It's just like in the thyroidectomy. They have to have lifelong. If it is total thyroidectomy, then they have to have thyroxine all their lives. So in the Cushing syndrome, in the Cushing disease, I meant, when the both of the adrenal cortex, adrenal glands are taken off, then they have to be on steroid all their lives. It's not the one that they say, oh, miracle happened, we're stopping. They have to have it all their lives. So it takes about a year or so after a lot of titration for the patient to start looking normal. I think we're going to have pediatrics and the rest in the next lecture. I'm going to stop here because I wanted this video to be like 1 hour. But when we come the next time, we're going to do this. So with just word of encouragement, keep going, you'll get it. I'm going to add this video to the other Nclex review videos. And yes, thank you all for watching today's video. And don't forget to subscribe, share to your friend that is also studying, leave your comments, and yeah, I'm going to see you all in the next video. Bye for now.